At ACC 2015, it is a beautiful day here in San Diego. I'm talking to Dr. John Laird, cardiologist, medical director of UC Davis Vascular Center. At this meeting, we've seen a lot of really important information on peripheral artery disease. And so that's what we're talking about here. We're here to discuss the recently approved IMPACT Admiral Drug-Coated Balloon for treating patients with peripheral artery disease in the superficial femoral and the popliteal artery. Yes. Now, you were one of the investigators of IMPACT SFA, which that study published in 2015 also. So we've got the circulation paper and material being presented here. Talk about the trial first off, because here we're talking about a drug-coated balloon.
Correct. So we're talking about a paclitaxel-eluting balloon that was tested in this trial in a randomized fashion against standard balloon angioplasty for stenoses and occlusions in the SFA and proximal popliteal artery. 331 patients were randomized in the trial, 2-to-1 between the drug-coated balloon and standard angioplasty. And what we found was that at 12 months, primary patency was dramatically better in the patients treated with a drug-coated balloon, 82% primary patency compared to like 52% with standard balloon angioplasty. And most remarkably, the need for target lesion revascularization or additional procedures was incredibly low, only 2.4% with a drug-coated balloon compared to 20% with standard balloon angioplasty. So the very favorable results of the trial ultimately led the FDA to approve the IMPACT Admiral balloon for use in patients in the U.S.
Now, in the mechanisms of how this works, it leaves some coating behind, and that's what helps keep an opening?
All the balloons are a little bit different in terms of how they work, but the primary mechanism is that the balloon is coated with paclitaxel and a carrier molecule or excipient, which basically allows the drug to come off the balloon and be delivered into the vessel wall where it sticks around long enough to have an impact on neointimal proliferation. So, for example, the Medtronic balloon, the excipient is a compound called urea, which is combined with the paclitaxel. The balloon is coated, 3.5 micrograms per millimeter squared dose. When the balloon is inflated in the artery, the drug comes off the balloon, is taken up into the vessel wall, and sticks around for at least 2 months, long enough to have an impact. And paclitaxel seems well suited for this type of approach because it's lipophilic and it's well absorbed into the plaque in the vessel wall.
Now, in the last few years, some drug-eluting stents have also been evaluated in this setting.
Right.
So now there's several different options, including the balloon. Where is one better than the other? Is there any indication in terms of which is the better choice?
Well, they haven't been compared head-to-head, a drug-eluting stent and a drug-coated balloon yet. There was a trial done in Europe, which I think just recently completed enrollment, so within the next year or so we may get some idea of which is better, the stent or drug-coated balloon. But for now, I think it's a little bit up to the operator and their preference and the lesion type. I think there are those who favor the approach of leaving nothing behind or leaving no metal in the SFA. So they like the idea of a drug-coated balloon and then only placing a stent if there's a really suboptimal result with that drug-coated balloon.
And why has it taken so long for drug-eluting stents to get used in the setting of the peripheral arteries?
Well, it turned out to be not as simple as people thought it would be. The companies, for example, Cordis and Abbott, attempted to make a drug-eluting stent using basically the same drug and the same polymer technology that they used in their coronary drug-eluting stents. And that, I think they expected that it would work. And at 6 months, there was a favorable outcome with regards to restenosis with a drug-eluting stent compared to the bare stent, but by a year and beyond, that benefit was lost. So there's something about the SFA, maybe it's the plaque burden, maybe it's the mechanical forces at play that make it a little bit more complicated. And there's really only been one drug-eluting stent that has so far been shown to be effective, and that's a paclitaxel-eluting stent. And there's really only one drug-eluting stent, that stent, that's approved in the U.S. for clinical use.
It's a fascinating field. And are you finding that there is more attention being paid to the peripherals now?
Yes.
At meetings like this?
Yes, absolutely. And I think it's important for for cardiologists to be involved in the treatment of patients with peripheral artery disease. A good percentage of our patients have concomitant peripheral artery disease. There's a very important need for better medical therapies for people with peripheral artery disease to reduce their risk of heart attack and stroke and premature death, as well as a need for ways to improve their quality of life and allow them to walk better and further and feel better.
Well, the paper by Dr. Laird and colleagues we talked about in CIRC, please check your video right after I say, hi, Rick McGuire, Executive Editor, CardioSource World News.